Welcome. This is the New England Journal of Medicine. I'm Dr. Michael Bierer. This week, September 12, 2024, we talk about treatments in newly diagnosed chronic myeloid leukemia and RNA therapeutics in mixed hyperlipidemia, a review article on clinical approaches to firearm injury prevention, a case report of a woman with edema, arthritis, and proteinuria, and perspectives on keeping SNAP in line with global evidence, on ingesting risk, on centering the peripheral brain, and how healthcare burdens patients. A new clinical decisions discusses medication for gastroesophageal reflux disease in infants. This case vignette of a 3-month-old infant with emesis after feeding and poor growth is accompanied by 2 essays, one recommending medication and the other supporting non-pharmacologic interventions. We want to know what you would choose. Visit NEJM.org to vote. Asciminib in newly diagnosed chronic myeloid leukemia by Andreas Hochhaus from the Universitätsklinikum Jena, Germany, and co-authors. Patients with newly diagnosed chronic myeloid leukemia, CML, need highly efficacious and safe long-term therapy. Asciminib, a BCR-ABL1 inhibitor specifically targeting the ABL myristoyl pocket, may offer better efficacy and safety and fewer side effects than currently available frontline ATP competitive tyrosine kinase inhibitors, TKIs. In this Phase 3 trial, 405 patients with newly diagnosed CML were randomly assigned to receive either asciminib or an investigator-selected TKI, including a stratum of imatinib and a stratum of second-generation TKIs. The median follow-up was 16.3 months in the asciminib group and 15.7 months in the investigator-selected TKI group. A major molecular response at week 48 occurred in 67.7% of patients in the asciminib group as compared with 49% in the TKI group and in 69.3% of patients in the asciminib group as compared with 40.2% in the imatinib group within the imatinib stratum. The percentage of patients with a major molecular response at week 48 was 66% with asciminib and 57.8% with TKIs in the second-generation TKI stratum. Adverse events of grade 3 or higher and events leading to discontinuation of the trial regimen were less frequent with asciminib, 38% and 4.5% respectively, than with imatinib, 44.4% and 11.1%, and second-generation TKIs, 54.9% and 9.8%. In this trial, comparing asciminib with investigator-selected TKIs and imatinib, asciminib showed superior efficacy and a favorable safety profile in patients with newly diagnosed chronic phase CML. Direct comparison between asciminib and second-generation TKIs was not a primary objective. Elisabetta Abruzzese from the Sant'Eugenio Hospital, Rome, Italy, writes in an editorial that the trial by Hochhaus and co-authors shows encouraging projections regarding efficacy and safety, complementing findings from Phase 1 and 2 trials. In the 2 primary comparisons, the percentage of patients who had a major molecular response at week 48 was higher with asciminib than with investigator-selected TKIs, and higher with asciminib than with imatinib. Early major molecular response is a surrogate marker to predict deep responses. However, these results were expected because molecular responses to second-generation TKIs are superior to those with imatinib, particularly in the short term, and the pre-selected imatinib population constituted 50% of the investigator-selected TKI population, representing an unbalanced group owing to age and coexisting conditions. The comparison between asciminib and second-generation TKIs did not show a significant difference for major molecular response at week 48. The safety and side effect profiles of asciminib appeared to be favorable as compared with those of imatinib and second-generation TKIs. Some 25 years after the introduction of TKIs, allosteric inhibitors are poised to further improve CML treatment. The current data on asciminib, summarized in the study by Hochhaus and co-authors, point to its future as a promising first-line treatment. However, before that can happen, it will be important to understand its effects on long-term safety, efficacy, sustainability, and quality of life, and to assess how it fares in a direct comparison with the more active second-generation TKIs. Additional time and work will be needed to place its role in the proper context. If asciminib, with its unique mechanism of action, significantly improves long-term safety and efficacy, it could mark another breakthrough. A new era in CML therapy is highlighted, but the journey to optimal treatment is far from over. Plozasiran, an RNA interference agent targeting ApoC3 for mixed hyperlipidemia, by Christy Ballantyne, from the Baylor College of Medicine, Houston, Texas, and co-authors. Persons with mixed hyperlipidemia are at risk for atherosclerotic cardiovascular disease due to an elevated non-high-density lipoprotein, HDL, cholesterol level, which is driven by remnant cholesterol in triglyceride-rich lipoproteins. The metabolism and clearance of triglyceride-rich lipoproteins are downregulated through apolipoprotein C3, ApoC3-mediated inhibition of lipoprotein lipase. This Phase 2b trial evaluated the safety and efficacy of plozasiran, a hepatocyte-targeted ApoC3 small interfering RNA, in patients with mixed hyperlipidemia, that is, a triglyceride level of 150 to 499 milligrams per deciliter, and either a low-density lipoprotein, LDL cholesterol level of 70 milligrams per deciliter or greater, or a non-HDL cholesterol level of 100 milligrams per deciliter or greater. 353 participants were assigned in a 3-to-1 ratio to receive plozasiran or placebo within each of 4 dose group cohorts. Results were pooled. At week 24, significant reductions in the fasting triglyceride level were observed with plozasiran, with differences as compared with placebo in the least squares mean % change from baseline of minus 49.8 percentage points with the 10 milligram quarterly dose, minus 56 percentage points with the 25 milligram quarterly dose, minus 62.4 percentage points with the 50 milligram quarterly dose, and minus 44.2 percentage points with the 50 milligram half-yearly dose. Worsening glycemic control was observed in 10% of the participants receiving placebo, 12% of those receiving the 10 milligram quarterly dose, 7% of those receiving the 25 milligram quarterly dose, 20% of those receiving the 50 milligram quarterly dose, and 21% of those receiving the 50 milligram half-yearly dose. In this trial involving participants with mixed hyperlipidemia, plozasiran, as compared with placebo, significantly reduced triglyceride levels at 24 weeks. Zodasiran, an RNAi therapeutic targeting ANGPTL3 for mixed hyperlipidemia, by Robert Rosenson, from the Mount Sinai Fuster Heart Hospital, New York, and co-authors. Angiopoietin-like 3, ANGPTL3, inhibits lipoprotein and endothelial lipases and hepatic uptake of triglyceride-rich lipoprotein remnants. ANGPTL3 loss-of-function carriers have lower levels of triglycerides, LDL cholesterol, HDL cholesterol, and non-HDL cholesterol, and a lower risk of atherosclerotic cardiovascular disease than non-carriers. Zodasiran is an RNA interference therapy targeting expression of ANGPTL3 in the liver. This dose-ranging Phase 2b trial evaluated the safety and efficacy of zodasiran in adults with mixed hyperlipidemia. 204 eligible patients were randomly assigned in a 3-to-1 ratio to receive subcutaneous injections of zodasiran, 50, 100, or 200 milligrams, or placebo, on day 1 and week 12, and were followed through week 36. At week 24, substantial mean dose-dependent decreases from baseline in ANGPTL3 levels were observed with zodasiran. Difference in change versus placebo, minus 54 percentage points with 50 milligrams, minus 70 percentage points with 100 milligrams, and minus 74 percentage points with 200 milligrams. And significant dose-dependent decreases in triglyceride levels were observed. Difference in change versus placebo, minus 51 percentage points, minus 57 percentage points, and minus 63 percentage points, respectively. The investigators observed a transient elevation in glycated hemoglobin levels in patients with pre-existing diabetes who received the highest dose of zodasiran. In patients with mixed hyperlipidemia, zodasiran was associated with significant decreases in triglyceride levels at 24 weeks. Pradeep Nadarajan from Massachusetts General Hospital, Boston, writes in an editorial that Ballantyne et al., who tested plozasiran, and Rosenson et al., who tested zodasiran, now describe the efficacies of hepatically targeted small interfering RNAs that target ApoC3 and ANGPTL3 messenger RNAs, respectively, among persons with mixed hyperlipidemia. Although their trials were not designed to test efficacy in reducing the risk of coronary artery disease, the drugs mimic the lipid effects of their genetic counterparts. The drugs were not associated with thrombocytopenia or hepatotoxic effects in these trials. The highest doses of each drug yielded a surprising, albeit modest, worsening of blood glucose levels among persons with pre-existing diabetes, but without worsening insulin resistance. Interpretations of human genetic studies have generally attributed the ameliorative effects of LDL cholesterol lowering and triglyceride-rich lipoproteins reducing targets on coronary artery disease to a reduction in levels of apolipoprotein B, a key protein in all atherogenic lipoproteins. Both plozasiran and zodasiran, as reported by Ballantyne et al. And Rosenson et al., elicited robust reductions in apolipoprotein B levels, largely through a reduction in remnant cholesterol levels. As predicted by genetic studies, zodasiran effected a greater decrease in LDL cholesterol levels. Zodasiran decreased HDL cholesterol levels, and plozasiran increased HDL cholesterol levels, findings consistent with those of genetic studies. Despite opposing effects on HDL cholesterol levels, the genetic studies predict fewer coronary artery disease events in both groups, and the current genetic and trial evidence generally indicates that HDL cholesterol is a non-causal bystander. Nevertheless, the sponsor plans to carry out a 3-group event-driven trial of plozasiran and zodasiran as compared with placebo. Clinical Approaches to the Prevention of Firearm-Related Injury, a review article by Patrick Carter and Rebecca Cunningham from the University of Michigan, Ann Arbor. Firearm-related injuries are an urgent health crisis in the United States, with firearm-related deaths surpassing deaths from motor vehicle crashes in 2017. In contrast to other conditions for which clinicians have evidence-based solutions to reduce harm, the 25-year gap in federal research funding halted substantial advances in the science of firearm-related injury prevention. Yet renewed funding and emerging science continue to highlight the critical role clinicians have in prevention efforts. Similar to other complex health issues, firearm-related injury is heterogeneous, with multiple causes. Each of these causes has entry points within clinical encounters that represent opportunities to interact, interrupt, and prevent negative outcomes. Clinicians should provide anticipatory guidance about firearm safety and storage in the context of routine clinical encounters, with tailored counseling for populations at elevated risk for specific firearm-related outcomes. Having these discussions should be normalized. They should be tailored to specific clinical issues and respectful of patients' firearm ownership decisions. Clinicians should be knowledgeable about a range of locked firearm storage options and tailor discussions to the patient. Repeated discussions with the patient and multiple small changes over time may be required to ensure that all firearms in the household are locked and unloaded. Ideally, firearms should be kept unloaded and locked in a storage device or container, with the ammunition stored and locked separately. Temporary storage away from the patient's household or where firearms cannot be easily accessed should be discussed in times of elevated or imminent risk of injury. Validated screening tools and evidence-based clinical strategies should be implemented in clinical settings in which patients at elevated risk for community and intimate partner violence are treated. Tailored counseling should be provided to patients at risk for suicide, cognitive decline, intimate partner violence, or community violence, and those caring for children. A 75-year-old woman with edema, arthritis, and proteinuria, a case record of the Massachusetts General Hospital by Beth Jonas and colleagues. A 75-year-old woman was evaluated because of arthritis, abdominal pain, edema, malaise, and fever. 3 weeks earlier, the patient noticed waxing and waning throbbing pain in the right upper abdomen, which she rated at 9 on a scale of 0 to 10, with 10 indicating the most severe pain, at its maximal intensity. The pain was associated with nausea and fever. During the 3 weeks before the current admission, edema developed in both legs. It had started at the ankles and gradually progressed upward to the hips. When the edema began to affect her ambulation, she presented to the emergency department. The patient's medical history was notable for multiple myeloma and seropositive erosive rheumatoid arthritis. Approximately 5 months before the current admission, the patient had emigrated from Central America. She lived with her daughter and grandchildren in an urban area of New England. Relevant clinical features on presentation included unintended weight loss and cachexia, axillary lymphadenopathy, serositis, cytopenia in 2-cell lines, hypocomplementemia, and elevated serum free kappa and lambda light chain levels with a normal free light chain ratio and no monoclonal spike. The white cell count was elevated, but she had no eosinophilia. She had proteinuria that was in the nephrotic range. CT images of the chest showed scattered sub-centimeter pulmonary nodules. Amyloid A, AA amyloidosis, a condition that is rare in the era of aggressive management of rheumatoid arthritis, has been described in patients with severe, long-standing, seropositive erosive rheumatoid arthritis. However, it did not fully explain the patient's kidney disease. A diagnosis of lupus nephritis was also made. Keeping SNAP in line with global evidence on food security, a perspective by Benjamin Krissinger from Tufts University, Medford, Massachusetts. Should the U.S. Supplemental Nutrition Assistance Program, SNAP, be reimagined as a nutrition-focused intervention? Recently, bipartisan proposals in Congress have explored this question, emphasizing the program's nominal attention to nutrition and drawing support from some researchers and clinicians. SNAP is currently designed to address hunger and food insecurity and is administered in the form of regular benefit allocations that can be spent only on food sold by approved retailers. Although hunger and food insecurity are related to chronic disease and poor health, some scholars argue that the program should go further to address the disproportionate burden of diet-related chronic disease in low-income populations. The proposals, despite their admirable goal of alleviating health disparities, don't devote sufficient attention to important concerns or alternatives that could achieve similar outcomes. Researchers have highlighted the importance of autonomy in welfare programs that preserve aspects of choice and individual agency. A larger question remains unaddressed by advocates of restrictions. Why should the United States primary food security program deviate further from global norms? Throughout the world, governments and non-governmental organizations have been shifting demand-side food security interventions away from food vouchers and food transfers and toward cash transfers. Evidence from cash transfer programs elsewhere in the world illustrates the ways in which poor health outcomes are often linked to having insufficient resources. Participants in cash transfer programs appear to invest in products and services that improve health. Ingesting risk. The FDA and New Food Ingredients, a perspective by Peter Cohen from Cambridge Health Alliance, Somerville, and Emily Broad-Lieb from Harvard Law School, Cambridge, Massachusetts. On June 22, 2022, Food and Drug Administration officials arrived at Stone Gate Foods in Minnesota to investigate the production of a new ground beef substitute. Consumers of the product had reported abdominal pain, nausea, vomiting, fever, and fatigue, and clinicians had found elevated liver enzyme levels in some patients. Multiple biopsies suggested drug-induced liver injury. Several patients had recurrent symptoms after consuming the meat substitute a second time. FDA inspectors at the facility uncovered no manufacturing problems or contamination with adulterants, pesticides, mycotoxins, bacterial pathogens, or heavy metals. The ground beef replacement contained only what was listed on the label. After nearly 400 consumers in 39 states fell ill, including more than 130 people who were hospitalized, investigators determined that a new ingredient listed on the product's label, tara flour, was found to be the most likely cause of the liver injuries. Nearly 2 years later, in May 2024, the FDA completed an independent safety evaluation of tara flour, finding that it was not generally recognized as safe, and therefore is an unapproved food additive. Before the new ingredient was introduced into the food supply, the FDA hadn't vetted tara flour, nor had toxicologic studies assessing its safety been published. This circumstance is not unusual. The legal framework governing the introduction of new food substances in the United States is based on the 1958 Food Additives Amendment, FAA. The FAA requires that all food additives be vetted for safety by the FDA before their introduction into the food supply. But the law also created an alternative pathway that permits manufacturers to bypass the FDA approval process. Substances that are generally recognized as safe aren't required to be approved by the FDA. Under current FDA rules, manufacturers may determine for themselves that a substance is generally recognized as safe, meaning that it has been adequately shown to be safe under the conditions of its intended use. Today, manufacturers overwhelmingly choose to bypass the formal approval pathway for food additives and instead introduce new substances that they have privately determined to be generally recognized as safe. Centering the peripheral brain. The History of Reference Tools in Medicine, a perspective by Andrew Leah from Brigham and Women's Hospital and Scott Podolsky from Harvard Medical School, Boston. Physicians have long warned that patients don't read the textbook, that neither patients nor diseases always behave as described in reference texts. Yet even as they have debated the uses and limits of texts, physicians have relied on reference tools for centuries as repositories of knowledge. The doctor's proverbial peripheral brain has taken on various forms, from textbooks and reference files to pocket guides and smartphones. Tracing the form and function of the peripheral brain in medicine illustrates the enduring yet evolving influence of reference tools on physician identity, thinking, and practice. Centuries before the so-called information age, scholars grappled with problems akin to information overload, as historian Anne Blair has written. For the Renaissance learned class, the development of new printing technologies and the discovery of new worlds occurred alongside emerging cultural attitudes of info-lust. Over the ensuing centuries, physicians would create reference books of all sorts, in part reflecting an apparent information explosion. Concurrently, from the 19th century onward, medical journals proliferated. Whereas textbooks aimed to synthesize this ever-burgeoning literature, the Index Medicus, 1879, was created by John Shaw Billings at the Library of the Surgeon General's Office to help physicians navigate directly to journal articles. In larger medical communities, centralized medical libraries emerged. On a smaller scale, for much of the 20th century, the medical library served as a teaching hospital's nerve center, essential to routine care. The history of reference tools demonstrates the ways in which the physician's proverbial peripheral brain is anything but. How does healthcare burden patients? Let me count the days. A perspective by Ishani Ganguly from Brigham and Women's Hospital, Boston. Healthcare contact days, defined as days spent getting healthcare outside the home, can represent access to needed, even life-saving care. But these days can also present substantial burdens, especially for older adults and their care partners. On top of the well-documented challenges associated with time spent in a hospital or nursing facility, ambulatory services such as office visits, procedures, treatments, imaging, and tests require time and result in transportation expenses, missed work, and other opportunity costs, not to mention the environmental impacts. Clinicians and healthcare systems should count and talk about healthcare contact days because there is both a need and an opportunity to be more thoughtful about how we use them. In a way, contact days are analogous to healthcare spending. Underuse of contact days, like underspending, is also problematic, since many contact days are, just as much spending is, beneficial. Contact days carry varying levels of burden, though even going in for a blood test can take hours, and they may also carry social benefits, an outing that is the highlight of an otherwise lonely week. But if we can achieve equal or better outcomes with fewer days or lower spending, as some studies hint, these excess days or spending may be worthy targets for reduction. Specifically, contact days could be optimized by reducing unnecessary care, coordinating care, and shifting care to the home when possible. Clinicians could talk with their patients about contact days, along with other meaningful measures of health and well-being, as they make shared decisions about, for instance, pursuing prostate cancer screening or starting treatment for Alzheimer's disease. In our Images in Clinical Medicine, a 53-year-old woman presented with a recurrent episode of severe diffuse abdominal pain. CT of the abdomen revealed segmental thickening of the walls of the colon and rectum and mesenteric edema. Laboratory testing showed low serum levels of C4, C1 inhibitor antigen, and C1q on repeated measurements, as well as decreased C1 esterase function. A diagnosis of angioedema of the intestines due to possible acquired C1 inhibitor deficiency was made. In another image, a 76-year-old woman with a history of parotidectomy on the left side presented with a 2-year history of facial sweating while eating. On examination, the left side of the face became erythematous and sweaty as she ate, shown in a video at NEJM.org. A diagnosis of gustatory hyperhidrosis, also known as Fraze syndrome, after parotid surgery was made. Gustatory hyperhidrosis occurs when there is aberrant reinnervation of the postganglionic parasympathetic fibers of the auriculotemporal nerve, most often after parotid surgery. During eating, this results in activation of cutaneous sweat glands instead of saliva production by the parotid gland. The condition is a common complication of parotidectomy, but typically occurs soon after surgery, unlike this case. This concludes our summary. Let us know what you think about our podcast. Any comments or suggestions may be sent to audio@nejm.org. Thank you for listening.